A very good evening to everyone. Today's clinical grand rounds will be presented by the Department of Geriatric Medicine. This will be the flow of today's presentation. We start by introducing to what is geriatric oncology, regarding the initial experience of our geriatric oncology clinic, intensive capacity among cancer patients, cancer survivorship in elderly, smoking cessation. We'll speak about the validation of chemotherapy toxicity assessment tools, and also the impact of GA-based interventions on quality of life. So we all understand that the population is aging, and in India, as of 2022, it was seen that nearly 150 million people were aged 60 years and above, and it is predicted that by 2050, this number will increase to 350 million, and they'll constitute nearly 21% of the entire population. So how many of the cancer patients are really older adults? In this study, which was conducted across 17 institutes across India, it was seen that among 272,000 patients who were registered, nearly 36% of the patients were aged 60 years and above. And among the male, head and neck cancer, lung cancer, and prostate were the most prevalent, whereas in women, breast, head and neck, and cervical malignancies were the most common malignancies. Another study which used the population-based registry database, which included data between 2012 to 2014, found that the number of patients who were aged 60 years and above was 46%. So what is the aim of performing a geriatric assessment? So we do understand that geriatric assessment tries to look at the patient beyond the presence of just the mere disease, and it's about evaluating multiple domains such as function, comorbidity, nutrition, the psychological status, the presence of polypharmacy and potentially inappropriate medication, as well as caregiver stress. So by doing this comprehensive evaluation, it helps the physician to stratify the older adult into either being fit, vulnerable, or frail. And this further helps the physician make a better personalized treatment plan for an older adult. So the geriatric assessment doesn't actually end at assessment. It also includes interventions which aim at optimizing the functionality of the older person, as well as providing psychosocial support. So in geriatric oncology, geriatric assessment can be has multiple steps, such as identifying the impairments in the geriatric domains, which I mentioned earlier, identifying individuals who are frail, to assess the risk of developing chemotherapy-related toxicity, to assess the global quality of life of such individuals, to understand the social and financial support, and very importantly, to also understand the wishes and goals of these patients as well as their caregivers. We also include caregiver stress assessment along with the patient assessment. So what are the effects or benefits of performing geriatric assessment? So in this single semester study, we tried to see if performing a geriatric assessment changed the treatment plan of older adult, found that nearly 38% of the patients had a change in treatment plan after the assessment. Not surprisingly, nearly 32% there was treatment de-intensification, such as reduction in the dose, or a couplet therapy was converted into a monotherapy. But we also see that in nearly 7% of these patients, there was treatment intensification. That is, initially on an evaluation, an oncologist might have felt that someone is frail or having a poor performance status. But by doing a detailed geriatric assessment, it was found that such patients were actually robust or fit, and their treatment was intensified. Geriatric assessment is also a good predictor of outcomes. In this, again, another single center study, which included nearly 900 patients, the entire population was divided into either having normal geriatric assessment or impaired geriatric assessment. Normal assessment was defined as either having no domains impaired or only one domain which is impaired, and impaired geriatric assessment was defined as impairment in 2 or more domains. It is seen that the overall survival was 24 months among those who had a normal GA, when compared to only 11 months among those who had an impaired GA. And these differences persisted even after adjusting for age, sex, primary tumor, as well as the metastatic stages. This is the Kaplan-Meier curve, which shows the result. A subgroup analysis was also performed among the fittest of the patients, that is, among patients who had a performance status of 0 and 1. And even among these patients, it was seen that patients with normal GA had a survival of 33 months, and those who had an impaired geriatric assessment had a survival of only 14.4 months. But doing the geriatric assessment has its own drawbacks, such as it is time consuming and you may require additional manpower. So, in addition to this, another study was conducted in which a screening tool was used and the predictive ability of the screening tool was tested. Here, the clinical field scale was used, which divided the population into fit, vulnerable, and frail. And we can see that those who were fit had a survival of 28 months, those who were vulnerable had a survival of 13 months, and frail individuals had a survival of only 8 months. Again, this persisted after adjusting for age, sex, primary tumor, metastatic status, as well as the ECOG performance status. Geriatric oncology at AIIMS is actually not recent. The work in this field has been carried on for more than a decade. In early 2013, Dr. Joyita Banerjee, who tried to develop a scale for Indian older adults with cancer and also to validate it, in following which she developed a care plan protocol. So the scale is called as Scope C. It's a screening tool, and she proposed that those who were found to have a good score in the scale should undergo standard treatment. Those who were found to be vulnerable, in them there should be treatment modification, and in those with poor score, such as less than 48 in men and less than 40 in women, such individuals should be considered for best supportive care. Another study which tried to look at the health-related quality of life among treatment-naive older cancer patients found that fatigue, loss of appetite, pain, poor function, and financial constraints were the major concerns or major issues among older adults with cancer. This study tried to compare three screening tools. One is Scope C, which was made in India. The other two were G8 and West 13, which are Western scales. So I tried to compare and found that there is maximum agreement between West 13 and G8, whereas there is moderate agreement between Scope C and West 13. And surprisingly, we also saw that Scope C was a better predictor of mortality when compared to G8 and West 13. There's also ongoing research and work continuing in India because geriatric oncology is currently in its state of infancy. There are also steps taken to try and develop guidelines to help clinicians, physicians, and oncologists to guide them as to how to develop their own geriatric oncology clinic so that they can provide better support and care for their vulnerable patients. So, Geriatric Oncology Clinic at AIIMS is currently at the National Center for Aging. It's a once-a-week clinic, which is collaboration between the Department of Geriatric Oncology as well as the Medical Oncology. It's a multidisciplinary team which includes the geriatricians, medical oncologists, psychologists, physiotherapists, as well as the dietitian. Now, I would like to call upon Dr. Ambika to continue with the presentation.
Thank you, Dr. Abhijit. So, presenting you the experience from our geriatric oncology clinic. So, we have had 297 patients in our clinic as of now. And the mean age of these patients have been 72 years. Most of the patients have been males, and in the education status, most of the patients have been illiterate. Now, this is a significant proportion with low literacy, which shows that it is important for us to formulate new health communication measures and intervention strategies according to the literacy level of the patients. Coming to the marital status and social history of the patients. So, most of the patients that came to our clinic have been married and are living with the spouse alive. Now, here, the patients with the spouse dead as a widowed group is important to note because it increases the risk of social isolation and eventually it causes health decline in our geriatric patients. A smaller proportion live with spouse only, and while only like few elderly participants live alone altogether. So this emphasizes the fact that most of the patients live with family and therefore they have strong family support as to which they came up to our clinic and seek help. Coming to the smoking and alcohol history, so more than 50% of the patients has had smoking history positive, while around 3/4 of the patients had alcohol history positive. This is important because we need to understand the impact of alcohol and smoking in the debilitation of the patients because the chronic health conditions that occur, they are profoundly attributed to the smoking history and alcohol history, especially as the person ages. Coming to the responsive questions that we ask in our clinic. So the first question, do you want us to disclose diagnosis to the patient? While in here, no attendant was present only with one patient, while the others, 55% said yes to the question and 45%, that is less than 50%, said no to the question. Now, this mixed response tells us that the status of autonomy and family involvement is really important in geriatric care, and we need, as physicians, need to individualize the treatment strategies. The next question, what is your expectation from the treatment? So most of the patients actually give more importance to the quality of life rather than just merely living longer with their debilitated conditions. So quality of life has been one star mark that our patients take off. And this focus on the long-term outcomes of the patient rather than just short-term benefits. Coming to the questions that are directed towards the financial concerns of the patients. So the two questions, have you avoided treatment due to financial concerns, and have you had to borrow money or sell assets to cover medical costs? This this question actually gives us an answer to how much impact the pockets of the patients have been on when it comes to the financial status and the financial impact that the treatment has. Heavy out-of-pocket expenditure burden in geriatric care is something we need to focus upon because that is important. Urgent need for strong financial risk protection measures either under government schemes or through NGOs or through health insurance coverage should be implemented. The types of malignancies have shown a diversity of cancer burden in our patients. As you can see, most common were the hematological malignancies paralleling the lung malignancies here with 30 and 29% respectively. Next as to gastrointestinal with 22% and urogenital and all other malignancies altogether combined as 10%. The symptomatology of the patient is really important to us because geriatric patients come to us with common complaints and not disease-directed complaints per se. So here, as you can see, the physical symptoms such as pain, lack of appetite, and loss of weight have been very predominant, and we should go ahead further into asking questions to the patient because these simple symptoms may give us a broad answer, and it may be as well as cancer apart from some basic medical conditions as well. So it also emphasizes the role of supportive and palliative care alongside the disease-directed treatment. Also, it tells us that the quality of life symptoms such as sleep are one of the measures that need to be seen in all the geriatric oncology patients. The incontinence habits, such as bowel habits and urinary incontinence in our patients, were lesser than 50% in both the groups, that is bowel and urinary. This shows that constipation was fairly a frequent complaint here, while incontinence, urinary incontinence in our patients was less common. While we have this result as of now, this is the condition when we have not started with the treatment of the patients. These incontinence features may further increase, and therefore re-evaluation of the patients is important, and it becomes also the important markers for frailty and functional decline. Coming to this cumulative graph, as you can see, it shows the number of medications. So as you can see, the red line in this graph shows that after number 5 medications, it actually plateaus. So beyond 5 medications, minority of the patients are on high medication counts, which is more than equal to 5, which accounts to polypharmacy. So this highlights the issue of polypharmacy, which is really important in our patients because of the side effects the treatment will have, and also according to the medical treatment that the patient is already on. Coming to next to the Charlson Comorbidity Index, since we all know that geriatric patients are supposed to have multi-morbidities very commonly, so this comorbidity index is really important to be concerned of. About 90% of the patients here show a score of less than equal to 2, and it indicates relatively low comorbidity burden. So only small fraction here scores more than equal to 3, and it reflects that minority are with a high comorbidity risk. This eventually shows that limited additional health burden have been there in most of the patient, and this may positively influence the treatment in the patients. History of falls in the patients have been no falls in majority of the patients, but again, this is the baseline data. As we go further, we really need to evaluate the fall status of the patients, because the balance and gait and also the cognitive status may also get impaired in these patients with the medical management along with their geriatric oncologic management as well. So this is one of the major important things. Coming to the nutritional assessment, so many nutritional assessment in our clinic, the majority are shown to be at risk of malnutrition, and they need early nutritional screening and re-evaluations with as per need interventions. Geriatric depression score, the short form, was done in our clinic to all the patients, and that shows that most of the patients had no or minimal depression. Similarly, most of the patients did not report anxiety. So this shows the psychological burden the patients already have, and going further, if the treatment started or a diagnosis is made of cancer, this may add to the psychological burden of the patient. Cognitive screening through Hindi mental state examination or mini mental status examination shows that most of the patients that came to our clinic had normal cognition, and again, this is one of the factors that is important in the geriatric history and management of the patients. Coming to the frailty distribution through clinical frailty scale, so this cumulative graph peaks around CFS 4 to 5. And this means that most of the patients are at the threshold of frailty. Nearly half of the population classified as frail, and frailty is actually a clinical determinant for the treatment tolerance and complication risks of the patient. Also, it adds to the survival outcomes of the patient. So, it is important to know the frailty status of the patient before the treatment, during the treatment, and after the treatment. These graphs show the activities of daily living distribution in the patient. So the first two graphs that we have seen show us that most of the participants, while they are independent in their basic activities of daily living in the first two graphs, while we see majority of our patients, 64%, they face impairments in their instrumental activities of daily living. This is important to us because for the independency of the patient while we give treatment to the person. So, as a whole, we come to the prevalence of geriatric vulnerability domains. In these domains, malnutrition has maximum value of prevalence here, followed by frailty, which is further followed by polypharmacy, and the least one is anxiety. Falls and cognitive impairment somewhere falls in between. So, as we see, most of these managements that we are doing pertain to what is the actual status of the patient and how do we go about it to have the best management with the best communication strategies. Thank you. So now I call upon Dr. Pramod to discuss a thesis on intrinsic capacity in older adults that was done in our clinic.
Thank you. So we'll discuss about the intrinsic capacity in older patients with cancer. In the past couple of decades, with the advancement of cancer treatment, the mortality has decreased, and the 1 year, 5 year survival rates are increasing now. As a result, more and more patients are being cured of cancer or are on prolonged treatment. For example, patients with prostate cancer or chronic hematological malignancy, they are on chronic treatment. So it is important that in addition to the curative treatment, we also now focus on the functional capacity and the quality of life for patients who are surviving. So in the previous decade, the concept of healthy aging emerged. The WHO defined healthy aging as a process of developing and maintaining functional ability that enables well-being in old age. And this functional ability is basically the product of patient's intrinsic capacity and the surrounding environment. The intrinsic capacity is the composite of all the physical and mental capacities of the individual, while the surrounding environment includes their social support, their family support, their access to healthcare, etc. So, if we go into intrinsic capacity, it can be divided into multiple domains. For example, the vitality or the nutritional status of the patient, and sensory domain, which include vision and hearing. We also include cognitive domain, then psychological domain, and locomotor capacity. So, including all this domain, the patient's intrinsic capacity is defined. So, if we see why is it important to assess intrinsic capacity in cancer patients? So, intrinsic capacity is affected by the cancer itself, or it can be affected by cancer symptoms like pain and anorexia, and it can also be affected by cancer treatment that the patient is receiving, like chemotherapy and radiotherapy. And as a result, it has been seen that different malignancies affect the intrinsic capacity of patient to different extent. Some affect the nutritional domain. Anorexia is very common. Some affect mood, and like depression, anxiety is common in cancer patient. Then cognition impairment is also seen, and mobility is also affected. As a result, it's important to do intrinsic capacity assessment to identify the patient who have impaired domains of intrinsic capacity, to identify this vulnerable population and to provide domain-specific interventions in these patients. So we conducted this study to assess the decline of intrinsic capacity and its domain in older cancer with prostate cancer, and compare the finding with that seen in healthcare seeking older adults without cancer visiting our OPDs. We included prostate cancer because it is one of the more common cancer that we see. It is the third most common cancer in Indian men, and worldwide is the second most common cancer in male. It is also a cancer that occurs mostly in old age. Most of the patients are aged 60 and above, and also it has a relatively higher survival rate compared to other cancers. So more and more patients are either on treatment or cured of it. So it's more important to maintain the functionality in these patients. We did a cross-sectional observational study and included 100 patients with biopsy-proven prostate cancer, age 65 and above, and 100 patients were age-matched without any prior history of cancer. We assessed intrinsic capacity using the WHO ICOP screening tool. We assessed the psychological domain, which included depression and anxiety assessment using appropriate tools. We assessed cognition, locomotion, nutrition, and sensory domains as well. So this is the baseline characteristic of the population. 69, the median age of the population was 69 years. Among the prostate cancer patient, 89% had metastatic disease and 92% were on treatment. As far as education is concerned, patients with cancer had a higher proportion of patients with higher education. Also, smoking and alcohol was significantly different between the two groups. Smoking and alcohol were more prevalent in the patients without cancer. Also, the prevalence of comorbidities like hypertension, diabetes, CAD, these were also more prevalent in patients without cancer. And as we have seen in the previous discussion, that cancer patients have relatively less prevalence of multimorbidity as compared to older patients visiting our general geriatric OPD. So in result, we found that different domains were affected to different extent. The most common domain that was affected was psychological domain, which was impaired in more than 50% of the population. Domains like psychological domain, locomotion, and nutrition were more affected in the cancer patient, whereas cognition and sensory domains were more affected in the non-cancer patients. However, there was no significant difference between the two groups. We also did a logistic regression analysis, which also where also we could not find any significant difference between the groups. We also assessed the composite score, that is the total number of domains that were affected, and we found that in both the groups, 18% of the population had no domains affected. Their intrinsic capacity was intact. On the other hand, around 82% of the population had affected one domain at least, and more than 50% of the population had at least two domains affected. So coming to the key findings of the study, significant portion of the participant had impairment of intrinsic capacity, and there was no significant difference between the two groups in terms of intrinsic capacity impairment, and it could be partially explained because of the higher proportion of patients with multimorbidity in the control group. The clinical implication of the studies is that since there is a high prevalence of intrinsic capacity decline in older patients, it's important it underscores the need of routine intrinsic capture assessment, and also including assessment in patients with oncology with cancer to help identify those who are at vulnerable high risk population. And future direction include seeing the association in more larger group, more diverse cohort, and also assessing the role of intervention to improve intrinsic capacity and quality of life in these patients. Thank you. I would like to call Dr. Chirag to discuss about cancer survivorship.
Good evening, everyone. So speaking of elderly cancer survivorship study, the prevalence of cancer in older adults has been increasing. It's reported to be 11.3 million in 2020, 19.8 million in 2040. It's expected to increase. 62% of the new cancers and 70% of the cancer deaths occur in individuals who are aged 60 years and above, and 45% of new cancers occur in older adults in India. And as the diagnosis of the cancer survivor as well as the treatment of the cancer was improving, there was an improvement in the survivor population also. As per the WHO, 53.5 million people living within the 5 years of cancer diagnosis in 2022, and in India, around 2.1 million people who are aged 45 years and above are found to be cancer survivors. So among the existing review of literature, there are a few gaps. First, the definition of the cancer survivor was not proper in the existing literature. The patients who are still having active cancer and who are on treatment are considered as survivors. Second, most studies lack a proper control group. That's why the long-term effects of the cancer as well as the treatment versus the normal aging was not clear in these studies. So in our study, we have a strict definition of survivors, that is post 2 years, cancer-free and treatment-free duration. And we also have a proper age-matched non-cancer controls to compare them. So coming to the objective and the methodology, we have to, the primary objective is to estimate the prevalence of the frailty in the older cancer survivors. We also aim to estimate the other impairments like the fatigue, the malnutrition, the cognition, as well as the mobility impairments in the geriatric domain and other geriatric domains, as well as the quality of life, and to compare these with the age-matched non-cancer older adults. It's a case control study, and the recruitment of cases was done from the medical oncology OPT and the controls from the geriatric medicine. It's being done from November 2023 to July 2020. So the cases were recruited who are aged 60 years and above and who have completed their cancer treatment for at least 2 years, and those who are having active disease and the relapse of the cancer diagnosis, or those who have any history of different primary malignancy in the past are excluded from this study. And for the control population, the age-matched controls with the normal laboratory value, and who do not have any unstable comorbidity, any history of any recent surgery or any psychiatric illness within past 3 months are included in this study. The sample size was calculated to be 124, comprising of the 62 cases and the 62 controls, with a margin of error of 7% and a power of 50. This is the workflow plan. The cases and the controls were included as per the inclusion and the exclusion criteria. And on the same day, the domains of the geriatric assessment had been done, had been analyzed for the. These are the domains as well as the test used. For the frailty, the frail scale was used. The depression, it's GDS 15. For the cognition, HMSC. For the mobility, TUC. For the nutrition, MNASF. For anxiety, GED 7. Fatigue severity scale. Basic ADL, SCADS index. Instrumental ADL, Notin index. Sensory and vision impairment, self-reported. And for the quality of life, PORTC, QLD, ELD 14 was used. Coming to the results, the median age of the population was found to be 70 with the comparable urban as well as the rural population. The multimorbidity burden was found to be higher in the control group with a significant p-value. Coming to the prevalence of the frailty, the survivor population is found to be have higher number of frailty as compared to the age-matched non-cancer controls. Speaking of other geriatric domains, the red button showing the impairment of the domains in the cancer survivors and the blue in the control. As we can see, every domain has been found to be more impaired in the survivor population group as compared to the control. And those domains that are being highlighted in the red box, that is the frail, that is the fatigue, hearing impairment as well as the malnutrition, was found to have even significant p-values. Coming to the regression analysis, the 3 models were constructed. Model 1 unadjusted, model 2 adjusted for the sex, and model 3 adjusted for sex as well as the multimorbidity. For the unadjusted model, The frail odds ratio was found to be 3.25. In nutrition, it's 3.43. In impaired ideals, it was 2.2. For model 3, that is adjusted for sex as well as morbidity, these are the various odds ratio of the various domains. Even the ideals as well as the fatigue has the highest odds ratio with 6.46 and 6.12 respectively. This is the forest plot showing the same odds ratio for various geriatric domains. The blue one was showing for the adjusted for the sex as well as the green for the adjusted for sex as well as multimorbidity. As we can see, the fatigue, the mobility, the hearing impairment, as well as the nutrition, the frailty was found to be significantly higher in the cancer survivor as compared to the controls in both the models. Coming to the quality of life, the scale we used comprises the 7 domains: the mobility, the joint stiffness, worries about others, family support, family worries, maintaining purpose, as well as the illness burden. And the mobility and the joint stiffness as well as the maintaining purpose was found to be significant p-value. And the odds ratio was significant in the joint stiffness domain. This is the forest plot depicting the same. As we can see, the joint stiffness was significantly higher in the cancer survivor, but the other domains are comparable in both. So in this study, what we found is that the frailty as well as the other domains, that is the fatigue, mobility issues, malnutrition, as well as the hearing loss, was significantly higher in the survivor group as compared to the control. That reflects the accelerated aging, as well as the long-term effects of the cancer diagnosis, as well as the treatment effects in this population. The multimorbidity that was found to be higher in the control groups was probable because the individuals that are diagnosed with the cancers tend to survive less when they have higher multimorbidity comorbid burden as compared to those who have less. And the quality of life is comparable to controls in the survivor age group, likely present the resilience as well as the adaptation in this particular survivor. So what we implied from this study is that the individuals who have a cancer diagnosis and who have won their cancer battle, this study still highlights the lasting impact of the cancer as well as the treatment on their geriatric health, as well as the need to integrate the comprehensive geriatric assessment into the survivorship care, so that the targeted interventions to maintain the independence has been done. Will be. Next, I will like to call Dr. Richa to
Good evening, everyone. Now I'm going to present a study on pattern of smoking cessation among elderly and primary caregivers after diagnosis of cancer. So as we all know that smoking is associated with almost 15 types of malignancies, the most common one being the lung cancer, followed by other kinds of cancers like esophageal, laryngeal, liver, stomach, kidney, pancreas, bowel, and ovarian and cervical cancers in female. So not smoking prevents all the 15 types of cancer, but what if someone is an active smoker and now being diagnosed with cancer? Is smoking cessation helpful in such patients? So it has been found that smoking interferes with the chemotherapy and radiotherapy effectiveness. Also, it increases the risk of treatment complications. Also, continued smoking increases the likelihood of developing additional primary tumors. So, in a recent study done in 2021, it has been found that those who quit smoking at the time of diagnosis have a better 5-year survival rate as well as progression-free survival rate in such patients in comparison to those who does not quit. So the objective of our study is to study the pattern of smoking cessation in elderly patients after cancer diagnosis and also the pattern of smoking cessation in their primary caregivers, in which it was a prospective observational study which was done in outpatients of medical oncology OPD as well as geriatric oncology OPD at NCA AIIMS New Delhi, in which we included patients aged 65 years or more with confirmed diagnosis of malignancy, those with tobacco-related cancer with primary sites of head and neck, lung, esophagus, gastric, colon, pancreas, kidney, urinary bladder, uterine and cervical cancers, those who were current smokers or history of smoking till the start of malignancy-related symptoms, with ECOG performance status of 0, 1 or 2 and expected to be under active medical care for the next 8 weeks and able to understand and comprehend and who gave informed consent, and we excluded those who withdrew consent who had baseline known CNS metastasis on active smoking cessation therapy since before the diagnosis of cancer were excluded. In our evaluation, we first took demographic data collection of gender, age, all the smoking, all the patterns of occupation and education. followed by cancer-related evaluation of the cancer type, stage in their ECOG performance status. After which we did a case operative scale that was to assess smoking habits, frequency, and duration. After this, we had an anti-cigarette awareness questionnaire in which we asked about how did they come across the facts about cancer, smoking associated cancer and its adverse events. We also did a recognition score, which was a measure of understanding of smoking risk and effect on cancer outcomes. After which we did an ambivalence score, which is about the measure of conflicting attitudes towards smoking cessation, and taking steps score, which is to measure their concrete actions taken towards smoking cessation. Finally, we did a symmetry and marginal homogeneity test. This was to assess their behavioral change towards smoking cessation. In total, we screened 831 patients, out of which 239 carcinoma patients were taken. 15 of them expired, 22 were lost to follow-up, and 202 patients were being followed for 8 weeks period. Also, we took 214 primary caregivers, out of which 27 were lost to follow-up, and 187 patients were followed up. Coming to the results, so in baseline characteristics, the median age was 71 years, with predominantly male patients, 93% of them, and lung cancer again being the most common type of malignancy which was seen, and most of them were found at the advanced metastatic stage. Looking at the smoking pattern in patients, so cigarette smoking was found in 26.89%, whereas BD smoking was more prevalent, being 74%, and 41.6% of them were taking 16 to 20 BDs per day, showing a high level of tobacco exposure among them. So 94.96% were reported a reduction in their smoking behavior after the diagnosis, whereas 5% did not alter their smoking habits even after diagnosis of cancer. So seeing the cigarette smoking pattern before cancer at baseline of first visit as well as 8 weeks follow-up, there was significant reduction in the number of cigarette smoking by the patients. Similar pattern was seen among the BD smoking patients as well. There was significant reduction in the number of BDs they were smoking per day. So we found that at 8 weeks follow-up, 83.1% of them completely stopped smoking and 16.8% continued smoking even at 8 weeks of follow-up. If we see the smoking pattern among the primary caregivers, we found that 81.78%, majority of them were non-smokers, whereas 18.2% reported current use of tobacco use. And among the users, cigarette smoking was more prevalent in comparison to BD smoking. But 82.05% did not change their smoking habit even after cancer diagnosis in their patients. If we see the pattern of smoking in primary caregiver, there was no significant reduction in the number of cigarettes they were smoking per day. And similarly, in BD smoking, they reduced the number at follow-up, but that was not very significant. So 41.6% indicated reduction in the smoking, whereas 58% reported no change in their smoking habits. So there is not much significant reduction in smoking pattern. So if you see the scores specifically, so in recognition score change, there was significant reduction, significant increase in both patients and primary caregiver. So which indicates that there was an improved understanding of smoking related risk. Also, in ambivalence score, it has been shown that there was significant reduction in the ambivalence, so they were less conflicting towards the habit of reducing smoking among both patients as well as primary caregivers. But when it came to taking steps score, there was not much statistically significant change among both patients as well as primary caregiver, showing a very moderate but meaningful progress towards solution efforts. So coming to the key findings of our study, so among elderly patients, 83.2% quit smoking within 8 weeks of cancer diagnosis, showing that cancer diagnosis can be a strong motivator. Whereas in contrast, only 41.6% caregivers reduced tobacco intake, and caregiver tobacco showed only minimal change with persistence of smoking. Seeing the case of this scale revealed that there was increased recognition and reduction in the ambivalence, but only moderate taking steps scores among the patients, showing only slight behavioral change among them. So coming to the clinical implications from our study, so diagnosis of cancer can be a teachable moment, especially in elderly patients. But we need targeted counseling and motivational intervention, which will help smoking cessation in patients. Also, primary caregivers require focused interventions beyond general awareness to facilitate their behavioral change. So, in future directives, we need to have a longer follow-up and implement tailored caregiver counseling to bridge the gap between recognition and actionable steps. Thank you so much. Now, I'd like to call upon Dr. Mihi to continue with the presentation.
Thank you, Rachel. Good evening, everyone. Now I'm going to present on validation of tools to predict chemotherapy related toxicity. So, existing oncological performance status, they measure the Karnofsky performance status and ECOG, that is Eastern Cooperative Oncological Group performance status. So, these scores they apply to all adult patients with cancer. They estimate the functional status, they assess eligibility for the clinical trials, they predict treatment toxicity and survival. But however, these are not validated in younger patients and they do not address heterogeneity in the aging process. So, what are the tools to predict toxicity risk? So, this is a prospective multicentric study that is predicting chemotherapy toxicity in older adults with cancer. So, it was done in patients of age more than or equal to 65 years with cancer among across 7 institutes, recruiting patients of 500. So, the pre-chemotherapy assessment included socio-demographics, tumor treatment variables, laboratory test results, and geriatric assessment. The toxicity, it was captured as grade 3, which was severe, grade 4, that is life-threatening or disabling, and grade 5 toxicity. So, this is a CARC score and the ability to predict its toxicity. The score is calculated as 0 to 19, where 0 to 5 is a low risk, 6 to 9 is intermediate, and where more than or equal to 10 is high risk. So, this is a study which shows the validation of prediction tool for chemotherapy toxicity in older adults with cancer. In the demonstration cohort, the toxicity among the low risk population was 30%, whereas in medium risk it was 51, whereas among the high risk patients it was 82. In the validation cohort, among the low risk, the toxicity was seen in 36%, whereas in medium it was 62%, and among the high risk it was 70%. So, is CARD predictive in all population? So, a study conducted in Australia in patients of more than or equal to 65 years with cancer, 126 patients from 2 sites were taken, and it was observed that neither the CARC score nor the oncologist's estimates based on the clinical judgment predicted the severe chemotherapy related toxicity in their population. So, it was concluded that methods to improve the risk prediction were needed. So, coming to the next study, predicting the risk of chemotherapy toxicity in older patients, the CRASH score. So, it's a prospective multicentric study which was done in patients of 70 and above. In 518 patients, severe toxicity was seen in 64% of the patients. And the predictors of toxicity were hemoglobin, creatinine, albumin, the ECOG status, MMSE, the mini nutrition assessment score, and the chemotox. So, this table shows the scores for the CARB score. So, this is a calculator showing the CARB score followed by the CRASH score. Coming to our research, our study, that is which predictive tool, that is CARB or CRASH, more accurately assess chemotherapy related toxicity in Indian older patients with cancer. So, it is a prospective observational study which was done in medical oncology OPD at AIIMS New Delhi. The inclusion criteria was older patients of age 65 and above with diagnosed solid malignancy receiving the first line chemotherapy, and the exclusion criteria was cognitive impairment which was diagnosed on MMSE of less than equal to less than 20. The sample size was 100. So, coming to baseline assessment, it included the demographic details and followed by the cancer related details which include primary tumor, histopathology, the ECOG PS status, geriatric assessment which include the functional status, that is instrumental activities of daily living, followed by nutrition which was scored based on MNA, followed by comorbidities on Charlson Comorbidity Index, psychological by geriatric depression score, and the chemotoxicity risk prediction tools used were CARG and CRASH score. So, the patients were followed up during each visit. It was seen the chemotherapy related toxicity grading was labeled according to CAE version 4, and number of emergency visits followed by chemotherapy, whether the chemotherapy was discontinued and whether the chemotherapy dose was de-escalated was noted. So coming to the results, total of 100 patients, the mean age was 69 and the 56 were male and 44 were female. Among the comorbidities, hypertension was more common, followed by diabetes and hypothyroidism. Among the primary tumors, lung cancer was most common, followed by gastrointestinal, then by genitourinary, then by breast, and the least in is head and neck. And among coming to the results, the performance status among the ECOG PS0, there were 2 patients, and both of them received the standard dose. ECOG 1, there were 57 patients, of them 46 received the standard dose and 11 received the reduced dose. In PS2, there were 33 patients and 15 received standard, whereas 18 received the reduced dose. And ECOG PS3, there were 8 patients, whereas only among them only 1 received the standard dose and 7 received the reduced dose. Coming to the car and crash at baseline. So car, the low risk patients were 28, intermediate risk were 54 and high risk were 18. The crash, low risk was 6, intermediate low risk were 52, followed by high risk, intermediate high risk were 37 and high risk were 5. Chemotherapy related toxicity, the chemotherapy was received by all 100 patients. Grade 3 or higher toxicity was seen in 44 patients. Hematological toxicity was seen in 23 and non-hematological in 36. So, the association in carg and chemotherapy toxicity, among the low risk patients, 17% patients had toxicity, intermediate risk 44% patients had toxicity, whereas high risk patients 77% had toxicity. In the crash group, low risk none had the toxicity, whereas intermediate low risk 23% had toxicity, intermediate high risk 70% and high risk 100% had toxicity. So this graph shows the ROC curve of both carg and crash. Both showing a value of 0.7, which was acceptable, where crash was slightly better than the carg. In this graph, the carg and emergency visits, among the low risk patients, 21% had emergency visits, intermediate 42%, whereas high risk 61% had emergency visits. Among the crash, also the low risk was 16%, followed by intermediate low risk 26, intermediate high risk 56, whereas high risk had 80% of emergency visits. The association with carg and chemotherapy discontinuation, among the low risk only 7% had discontinuation, whereas among high risk 33% had discontinuation. And crash and chemotherapy discontinuation, among the low risk there was no discontinuation seen. Intermediate high risk had 24.3% discontinuation, whereas high risk had 20% of discontinuation. So the key points are both carg and crash predict chemotherapy related toxicity with good discriminatory ability. They predict both emergency visits as well as the predictor of chemotherapy discontinuation. I would like to call Dr. Shubham Raikar to continue the.
So we did a study in our department to assess the impact of geriatric assessment based intervention on health related quality of life of older patients with cancer. Next, first of all, let's understand what is comprehensive geriatric assessment. It is a systematic, multidimensional diagnostic and therapeutic process that evaluates medical, psychological, functional, and social domains in older adults to develop coordinated, individualized care plans. So these are the domains evaluated with geriatric assessment, including physical performance, functional status, medical problems with daily medication use, cognition, psychological status, nutrition status, and social status. Now let's understand what is health-related quality of life. It is a multidimensional construct encompassing physical, emotional, functional, cognitive, and social well-being from the patient's perspective. In oncology, it has evolved as a crucial outcome measure, particularly in the context of older adults, where the primary goal may not always be the cure, but the preservation of function, independence, and dignity. So in this figure, we can see on the right, these are the factors which deteriorate the health-related quality of life, while on the left are the factors which augment the health-related quality of life. So in this study, our primary objective was to compare the impact of geriatric assessment-based intervention with standard care on health-related quality of life in older patients with cancer. Also, we saw the overall survival and chemotherapy toxicity between these two groups. So this was a randomized control trial done in the outpatient department of NCA and IRCH between July 2023 to June 2025 with a sample size of 130 patients, and these patients were randomized 1:1 using the computer generated software and followed by randomization using the SNOS method. So the 130 patients were assessed, which were randomized into 66 patients in the intervention group and 64 patients in the control group. These in the intervention group, interventions were given based on geriatric assessment findings
followed by oncology treatment, and in the control group, geriatric assessment was done, followed by oncology treatment, and these both groups were followed up at 0, 3, and 6 months for health-related quality of life. We included patients above 65 years and above of age with diagnosis of solid malignant neoplasm and ECOG 0 to 2 who have the ability to give written informed consent, and they were treatment naive. We excluded patients who denied participation with ECOG performance status of 3 and 4 at hematological malignancies. So the domains assessed in this study included the functional status assessed using ECOG, ADLs, IDLs, history of falls, TUG, and SPPP, followed with detailed evaluation, physiotherapist intervention, and drug optimization was done. For psychological status, GDS 15 and GAD was done, followed by psychoeducation, CBT, psychiatry, and psychology referral. For nutrition, unintentional weight loss, MNSF was done, followed by dietitian referral for personalized diet chart and counseling on oral care and ability to eat. For cognition, HMSC and history of memory loss was recorded, for which review of medications, detailed cognitive testing involving caregivers and delirium prevention was done. For comorbidities, Charlson Comorbidities Index was used, which were managed by us considering risk stratification and care goals discussion. For polypharmacy was also assessed, and which was managed using the Beers and start-stop criteria. Other abnormal findings including CAR score, pain scale, urinary and bowel incontinence, followed which palliative care, reduced care, chemotherapy dosing, uroflowmetry, urologist referral was done. So in the intervention and control group at the baseline, these characters were similar in both the groups with a p-value of more than 0.05. So the intervention, these were the interventions given. Out of which the most common intervention given was dietitian referral, followed by pain management and physiotherapy. These patients are analyzed at baseline and 6 months. From the baseline, the scores were calculated using the EORTC QLQC 30 for health-related quality of life. In these scores, we found out that there was improvement in all the domains of this scale in the intervention group, but there was significant improvement in the quality of life and the role function. Similarly, we used another scale, FACTG scale for health-related quality of life. In this scale, also we found that there was a significant improvement in the physical well-being, social well-being, functional well-being, and FACTG total scores. We also calculated the chemotherapy toxicity using the CTCAE criteria in the intervention and control group, and we found that there was improvement in reduction in chemotherapy toxicity in the intervention group compared to control group. And at last, we calculated the survival in the intervention and control group. This survival were not different in both. So key findings, what we found out that in EORTC QLQC 30, there was improvement in quality of life and role functioning domains in the intervention group, which was significant. In FACTG scale, we found out that there was higher scores of improvement in physical well-being, social well-being, functional well-being, and FACTG scores. In chemotherapy toxicity, we saw that there were mean toxicity grades were lower in the intervention group compared to control group, and there was no difference in the survival in both. So at the last, clinical implications. So based on this findings, we found that we should integrate the geriatric assessment in the routine oncology practice. Also, to implement the tailored multidisciplinary interventions, we should develop standardized protocol for GA-based intervention and use of these findings to guide treatment decisions. And last but not the least, we have to strengthen the interdisciplinary collaboration. Thank you. Now, I would like to call Dr. Pramod for concluding this.
Thank you. So we started this clinic around 1.5 to 2 years back with the support of a medical oncology team. And the main goal of the clinic was to make cancer treatment more feasible, more approachable for older patients who have multiple comorbidities, multiple geriatric syndromes, and also to get CGA geriatric assessment done for these patients and provide them a more holistic care at one center, and also to get create good quality data in this relatively new field of geriatric oncology. We have assessed around 250 plus patients, 300 patients, and the number is increasing every week. At the end, I would like to thank our colleague from the Department of Medical Oncology who have been there since the very inception of this clinic in the implementation and in the formulation and implementation of this clinic protocols. Also, I would like to thank our dietitian, physiotherapist, also psychologists who have been there providing holistic care for these patients, cancer patients. A special mention of Dr. Nidhi Suni, who is a faculty here and is the main backbone of the cornerstone of the clinic, who has been formulating the protocols and SOPs for the clinic. But she could not be here due to some personal reasons. And also a special thank you to our seniors, Dr. Avinash, and our HOD, Dr. Navitri, for their guidance. Thank you. So we come to the conclusion of this presentation. Any comments or questions? No comments. So thank you.